Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health Center, reporting for the week of August 22nd, 2022. Today, I'm going to give a COVID update, and then I'm going to talk about some new interesting data and findings regarding long COVID, and then I'll provide a monkeypox or MPX update. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we are here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. In Alameda County, just like much of the country, cases do appear to be heading in the right direction now for a sustained several weeks now. So that is good news. Likewise, our positivity rate, while still high at around 8%, is definitely coming down as well, heading in the right direction. And when we look at hospitalizations, we're still kind of seeing this zigzagging. We have 128 people in the hospital, 19 of those in the ICU. But this is hopefully going to be an improvement overall. We will be keeping a close eye on that. When we look nationwide, unfortunately, we are still seeing this really high plateau of deaths. And this is very concerning. This is for August 21st. We're seeing 575 deaths. We've really been sort of vacillating between 450, 550 deaths, somewhere around there. That's over 180,000 people a year. If it continues like this, of course, we're concerned about another fall and winter surge like we've had ever since this has started. And I just want to point out that last summer, sort of that June, July 2021 timeframe, we were at about half this many deaths a day, somewhere in the 250 area a day for several weeks. And so it's definitely concerning because then we really didn't have Paxlovid treatment. And so for us to be in the situation now where we've got double the deaths of last summer, it's just not a great place to then be heading into fall and winter. So this is certainly something that should be of concern to us all. We continue having 35,000, 40,000 people a day in the hospital, 4,000, 5,000 of those in the ICU. So still quite a bit of sickness and death from SARS-CoV-2 in the United States. And looking at the variant proportions, not a huge change from last week. Last week, the BA 4.6 was 5%, now it's 6.3%. So very slowly kind of displacing the other variants, and it may just continue to do that. It certainly looks that way. And here in California, we're still seeing kind of a similar pattern where folks who are unvaccinated are more than 11 times more likely to die from COVID-19 than those who are vaxxed and boosted. And we still don't know who out of these folks was treated or not, but we know that the treatments are reducing hospitalization and death by about 80%. So we really want to ensure that vaccinated or not, that folks who need treatment get it quickly if they are diagnosed with SARS-CoV-2. So, but we do know that hospitalization and death are not the only unwelcome outcomes from COVID. And we've all heard about long COVID. There's probably more we don't know than what we do know. I did a pretty thorough overview of long COVID and post-COVID, including like the definition and how common it is and so on. Back in March. The link to that briefing is in the post if you want to kind of do a deeper dive on just an overview of long COVID. Today, I wanted to talk about sort of Some of the findings that really have been published this month, hopefully this is just the beginning because there's a lot of different studies going on. It really is urgent that we understand what is happening so that we know what to do about it. Maybe we'll learn how to prevent it or at least predict it. Maybe we'll learn how to treat it or even cure it. But right now we are sort of far from that, and we're just kind of barely scratching the surface. But I think it's good news overall. That we are learning, I guess, that we are making progress on learning. So I wanted to talk a little bit about why we think long COVID might be happening. And I don't think that we know for sure. And so there's just a lot of theories out there. And so some of the theories is that maybe the acute infection of SARS-CoV-2 like damaged tissue or damage your organs to where that is just persistent damage going on. That is possible, or is it possible that the virus is just persisting in the body and it's kind of like hiding out somewhere and it's causing sort of this low-level infection to just continue? Other theories have to do with whether there is an autoimmune response, or did we just disrupt the whole, balance that's going on in our body between friendly bacteria and viruses and unfriendly ones and so forth. So we just kind of messed up the whole biome there. Or could it be that there was other latent viruses that got reactivated? And this is a theory that I have talked about a little bit as it related to the children who are getting hepatitis and liver failure in the post-COVID period. And there was some thought that it could have been a reactivation of a different latent virus that was happening because of the COVID. So all these different theories, there's probably more theories than that, but those are the main working theories that I've seen. And they're kind of all over the place. And we need to really hone in on if it's one of these or more or something else, because that will hopefully help guide any kind of treatment or prevention strategies that we might be able to come up with. One of the articles that was published this month was the August 5th Morbidity and Mortality Weekly Report from the CDC, and I just want to briefly talk about it because this is one that was specifically looking at young people 0 to 17 years old. And basically it showed that those who had COVID had higher rates of some pretty serious adverse effects within 1 month to 1 year following their COVID infection. And that included a pulmonary embolism, which is a clot to the lungs. It can be very serious, can be fatal. Myocarditis and cardiomyopathy, so sort of inflammation of the heart and disease of the heart that causes it to become enlarged. Or other clot events. We've heard about this in adults as well. Also kidney failure and type 1 diabetes. And these were all significant findings. And there were others as well, but I really just wanted to point this out to say we're not only talking about, an adult phenomenon, we're also not only talking about, sort of symptoms like saying fatigue, even though those are very real symptoms. These are actual events that are occurring and sending even young people to the hospital. So even though the overall numbers are not large, it was a statistically significant increase post-COVID for young people aged 0 to 17 to have blood clots to the lungs and elsewhere, kidney failure, heart issues, type 1 diabetes. So this is all quite concerning, and I really just wanted to bring this up first because it was a newly published, but also because I think it really underscores the urgency around understanding what is it that this virus is doing in certain people that has these effects that last longer or that are coming up, even a year or two after the acute infection. And so another study that was published this month was a 2-year retrospective, so taking a look back at a cohort of individuals who had COVID-19. And this was pretty large, quite large. It was a international network with electronic health records of about 89 million patients. And these were from hospitals and primary care, from mostly the United States, but also from several other countries. And they were looking at folks who were infected all the way from January of 2020 to April of 2022. And they basically did matching to another cohort of patients that had any other respiratory infection, not SARS-CoV-2. So kind of interesting, because it was looking at folks who might have had another viral respiratory illness. And they matched based on a number of different factors, demographic factors, but also the risk factors for COVID and for severe COVID. So they did a lot of work to kind of match these, as well as matching based on vaccination status. And they separated out by age groups. And they looked at the risk of 14 different neurological and psychiatric diagnoses after SARS-CoV-2 infection. And then they compared those risks with this matched cohort that they were comparing to. And the risk of psychiatric disorders like mood disorders or anxiety and things like that, the good news is those returned to a baseline for the most part after a couple of months. And after a little bit more than a year, that group looked almost the same as the group that didn't get COVID, but it did take 457 days for folks with mood disorders, and for folks with anxiety, 417 days. That was when that whole group kind of returned to the baseline and matched the other group that had a non-COVID respiratory illness. So I think the good news there is that some of these mood disorders, anxiety, and so on do seem to be returning to normal, at least by this study. Unfortunately, when there was more severe findings, so the cognitive issues or the inability to concentrate, some people call that brain fog, dementia, psychotic disorders, seizure disorders, these are all findings that we have seen after SARS-CoV-2 infection. And unfortunately, this was still increased at the end of the 2-year follow-up period. So 2 years in, and some of these more severe neurological and psychiatric issues were still persistent 2 years down the road. And when they looked at children, because remember I said they separated out by age group, they noticed something a little bit different. They saw that there was actually not an increased risk among children of the mood disorders or the anxiety disorders. So that was not a factor in this study that they found. However, they did see that latter group, the more severe group, cognitive issues, even bleeds inside the brain, strokes, and other kind of neurologic issues and psychotic disorders, as well as seizures. And we are seeing that as well in post-COVID in children. And that was something that also persisted throughout this 2-year look back, unfortunately. So the fact that there are sort of different timelines for these different issues also suggests that there's probably something different that underlies those diagnoses. And so it's not, so there must be different sort of mechanisms of how these things are happening. And the other thing that they saw was that the neurological and psychiatric outcomes were actually pretty much the same during the Delta wave and the Omicron wave. So this, I think, just signals for us that there are some outcomes that we need to be more concerned about, like seizure disorders or like other cognitive deficits that people may be having. They may persist for a long time, and we still have a lot of work to do to try to understand better what is going on there. And the one that I think I'm most enthusiastic about sharing here is still in preprint, but I wanted to share it because I think there are some really interesting findings that I believe are going to be leading to a lot more study and hopefully a lot more progress in terms of our understanding of long COVID. This study is called Distinguishing Features of Long COVID Identified Through Immune Profiling. And so this study basically really sought to kind of do a deeper dive. So as opposed to the one I just mentioned with 89 million patient records, this was a relatively smaller cohort, 215 participants. They had them divided up into 4 different groups. And so it was people who never had COVID, people who recovered from COVID and were more than a year out with no issues, and then a group of people who had COVID who were healthcare workers who were more than a year out, and then those with persistent symptoms after COVID, so long COVID. And what they did was they were just very systematic about doing a whole lot of analysis on the blood. They used machine learning. They aggregated data, and they were really looking for any potential biomarkers of long COVID. They also did a pretty deep dive on the symptoms. And this was something I reviewed in a lot more detail. The broader list of symptoms, there's like over 200 symptoms that people have identified with long COVID, but the ones that really seem to be rising to the top in terms of what folks with long COVID, with the persistent symptoms that they're experiencing, this fatigue, that's pretty significant. It doesn't go away. Also malaise after exertion, so really tough to do the activities that they were doing before, and then also some of the cognitive issues, and also autonomic dysfunction, so symptoms like when you stand up getting dizzy or even almost passing out, so kind of this little bit of a dysregulation going on there, and that's something that we're seeing fairly commonly. So those were identified through this study. And they did a lot of analysis on all the different types of blood cells. And so I'm going to do my best to just, relay these a little bit simplistically. So first of all, those with long COVID did not have an increase in autoantibodies. So I think this is a big relief because, we don't want to hear that SARS-CoV-2 is causing an autoimmune disorder, because we are really talking about millions of people who, likely have long COVID, and to have that much burden of autoimmune disease, I think could be quite significant. So I found this to be a relief. No autoantibodies noted in the long COVID group. What they did find was elevated inflammatory and antiviral immune responses. So different blood cells that increase during inflammation were found in the long COVID group. So what is going on there? That's something that we're going to need to learn more about. What they also found was increased and persistent antibodies against SARS-CoV-2. So still kind of having antibodies against COVID, even though the acute infection was over. So kind of this combination between inflammatory and antiviral immune cells being present, as well as these persistent antibodies against SARS-CoV-2, makes you wonder, is there a source of SARS-CoV-2 that's sort of persisting, like a low level of this virus? Is it kind of hiding somewhere and the body is still producing these antibodies against SARS-CoV-2? So more study will be needed, but they did find sort of specific elevations in these types of cells. The other thing they found is an unexpected increase in antibodies against herpes simplex virus and Epstein-Barr virus, which is also in the herpes virus family. And Epstein-Barr virus, if you remember, mononucleosis, and it has been linked to chronic fatigue syndrome. We're not 100% sure about Epstein-Barr and chronic fatigue. There's just so much we don't know. But there are some things about long COVID that are definitely overlapping in terms of symptoms with chronic fatigue. And so could there be some kind of correlation? Could this be a reactivation if someone had sort of a dormant herpes infection, a dormant Epstein-Barr virus infection, this reactivation of antibodies directed against these two viruses in the group of long COVID folks specifically compared to people who don't have long COVID, indicates that there may be a role, maybe reactivation of these viruses. And again, that was somewhat of a working theory with the hepatitis in children that we were seeing post-COVID. And so that will be yet another thread that we'll want to kind of follow along with what's going on with long COVID. Probably the most striking finding is that the cortisol levels of people with long COVID were quite a bit lower than those who don't have long COVID. And this is sort of not very intuitive because cortisol levels are associated with stress. And so you might think, well, long COVID seems like a stressful thing. Why would cortisol levels be low? Is it cause? Is it effect? Is it just correlate? We really don't know. But we do know that we've seen low levels of cortisol in chronic fatigue syndrome. So there does seem like maybe there's some kind of correlation going on there. We still have a lot to learn about why this is happening, but very, very significant to have cortisol levels be less than 50% or more than 50% lower essentially than those who don't have long COVID. And so that's very significant and definitely will warrant more study. But not only that, could it be used to actually predict who's going to have long COVID? Is there something we can actually do? Is that going to be a place where we can intervene? So again, it's still a lot to learn. And so right now there are dozens literally of studies going on about long COVID. There are numerous drug trials. I put several links in the post to where you can find a long COVID center. Also what studies to watch around some of the pharmaceutical interventions that are being trialed right now. There were sort of treatments being studied and in the pipeline for chronic fatigue syndrome. Those are being kind of studied in relation to long COVID as well because of some of the similarities I've already mentioned. But at this point in time, and you know, the estimates of how frequent this is are all over the map, but even with the most conservative estimates, we're still looking at millions upon millions of folks with long COVID. So it feels like another crisis kind of coming along on the heels of a still evolving current public health crisis. And so we really need to continue to learn more about this and to not give up hope because we definitely have heard of folks getting severely depressed, even having thoughts of self-harm around the debilitating nature of long COVID for some people. And I really just want to encourage us to stay hopeful. Keep up with the studies. Look up a long COVID center. They have the ones nearby are in UCSF, at Stanford, at Davis. They even have virtual long COVID centers. And so we'll continue to learn more and more. And I think the other pieces that we just don't know enough about is you know, do the chances of getting it increase or decrease with more and more infections? But I think the bottom line, based on what we do know right now, is that we want to do our best to avoid catching SARS-CoV-2 in the first place or catching it again. We don't want to have repeat infection on top of infection because we just simply do not know what those cumulative effects may be. And so in the meantime, we want to continue to prevent ourselves from catching it because we are learning more and more every day. And hopefully we'll learn how to prevent long COVID or at least treat long COVID. And so now shifting to a brief MPX update, cases continue to climb. We're over 41,000 worldwide, over 14,000 in the United States, and over 2,600 in the state of California. We've now got, we've got more than 144 cases here in Alameda County. And so this just kind of continues to rise. And you can see here nationwide on the map, the darkest blue color there is where we are seeing the greatest number of cases. Unfortunately, there is a big lag time in the turnaround of these tests, and also in terms of confirming it before they end up on these dashboards. So I just want to flag that we've already got quite a bit more than actually what's even showing here. But really, the vaccine is available if you are in a higher risk category. So if you have had multiple or anonymous sexual partners, male sexual partners, then you are likely a candidate, and certainly if you have been exposed. And so if you are in those categories, please get yourself a vaccine. There's a link in the post to the resources here in Alameda County. And definitely, if you have symptoms or you think you're exposed, please seek care. And if you have any lesions, then those should be tested, not just for MPX, but also for herpes and for varicella virus. And so you don't just have to only have one thing, you could have other things. And so certainly if you've been exposed, you may even need blood drawn to check for other things as well. So very important to seek out a healthcare provider for that. And definitely, if you think you're exposed, please try to seek that vaccine, because the one thing we've got on our side with MPX is that it has a pretty long incubation period. And that means that after exposure, you can get the vaccine and keep yourself from catching it altogether. So a recurring theme through all of this is being up to date on your vaccinations. If you're due for a booster for SARS-CoV-2, please get it. If you're eligible for an MPX vaccine at risk of contracting MPX, please get that vaccine. And if you are not up to date on any of your other vaccines, really now is a good time to check. I would be pulling out your vaccine records, make sure you've had all your polio vaccines. I talked last week about the resurgence of polio. And so we want to make sure that we are just up to date on all of our vaccines. It's one of the modern inventions that has changed our life, and we certainly should not forget about it unless we'd like to go back to a pre-vaccine era, which was not pretty. And so I would just encourage us to use the tools that we have available to us. As it relates to SARS-CoV-2, please make a test and treatment plan, because we keep hearing we have the tools, but if we don't use the tools, then we still got more than 500 people dying a day. And it's just really horrendous. And we cannot just sort of rest here, because this is not a good state of play we are in. And part of the challenge is that so many of the mitigation strategies have been dropped, which means that it becomes more and more incumbent upon each individual to do what they have to do to protect themselves, because now we don't have people sort of universally practicing caution. And so we want to see where we feel comfortable. Where do we feel comfortable gathering outdoors, and where do we feel comfortable that people are masking or being cautious? And for a lot of people, unfortunately, they've had to shrink their circle further or reduce some of the activities they're doing. And I think this is really, really unfortunate, because we all have a right to enjoy public spaces. And I don't think wearing a mask is really too much to ask just to protect one another. I think it shows care and respect for one another. It's unfortunate that not everyone feels that way. They don't. But I really am still holding out hope that maybe we'll have certain hours at some stores where everyone masks, or flights that are masked flights. I know that would be my preference for sure. But until then, it's up to each and every one of us to just increase our own self-protection. So that means stepping up with your masks, make sure it fits you well, make sure it is a filtration mask, a KN95, an N95 ideally, or KF94. They even make these for little people. So if you've got little ones, especially in school where there's a lot of mixing going on and not universal masking anymore, it's really important to step up on the masks. If you're someone who is at high risk, you're over 50, you've got underlying conditions, and certainly if you're unvaccinated, you are at the highest risk, 11 times higher risk of dying. So you are someone who should definitely have a treatment plan. And so making sure you're getting tested right away if you have symptoms or exposure, and getting treated as well. And let's not forget about Evusheld. So far seems to be holding up against all these different variants, gives 6 months of antibody protection for those who might not mount a good response to the vaccine. So immunocompromised, on steroids, on medications that suppress the immune system, chemotherapy, post-organ transplant, etc. If you don't have a primary care provider, please get one. And as usual, take good care of yourself, manage your stress levels, get outdoors, get some good exercise, eat a balanced diet, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us. If you have any questions, please email them to admin@rootsclinic.org or send them by the chat. And we look forward to seeing you next Tuesday at 10 a.m. See you then.